This USMLE style question about shock. A 65-year-old man presents with severe chest pain for 2 hours. He's confused, diaphoretic, and short of breath. It seems acute coronary syndrome. His blood pressure is 78 over 50. Heart rate is 120 per minute. He's tachycardic. He's hypotensive. His oxygen saturation is 89% on room air. Physical examination shows cool, clammy extremities, elevated jugular venous pressure, and bilateral lung crackles. ECG shows an acute anterior STEMI. This looks like acute cardiogenic shock. Guys, the pathophysiology of cardiogenic shock is when the heart fails to pump, okay? This leads to accumulation of blood inside the heart, okay, which increases the pressure inside the heart chambers and therefore reduce the pressure gradient that drive the venous return from the draining veins to the left atrium and right atrium, okay? Left ventricular failure will lead to back pressure in the pulmonary veins, leading to pulmonary congestion, which will cause pulmonary edema that can be heard as bilateral basal crackles, okay, on auscultation. And then the right side of the heart failure will cause systemic venous congestion and increased central venous pressure, okay, in the superior vena cava and its draining veins and the inferior vena cava. So there will be jugular venous distension, lower limb edema. Okay, guys, let's differentiate between different types of shock. First of all, we have hypovolemic shock, cardiogenic shock, obstructive shock, and finally distributive shock. The first three types share that because of the reduced cardiac output and reduced tissue perfusion, the sympathetic nervous system cause vasoconstriction to peripheral arteries, increasing the systemic venous resistance. Okay, this allows blood to pass slowly through the vessels, which leads to more oxygen extraction in the tissues, okay, and the venous oxygen content will be measured lower, okay, and the skin, because of the skin blood vessels vasoconstriction, will feel cold in those three types. Okay, let's differentiate between them. Hypovolemic shock is simply because there is loss of intravascular volume, maybe due to hemorrhage, burns, GI losses such as vomiting, diarrhea, DKA from the polyuria. Okay, here I have reduced pressure inside the blood vessels all over the body. So the central venous pressure will be low, the preload will be low, so there will be flat jugular veins, the pulmonary capillary wedge pressure will be low, okay? And the cardiac output, as we just said, is low because the effective circulatory volume is low and the stroke volume will simply be low, okay? Cardiogenic shock, as we just explained, because of the pump failure, the heart reduces its contractility. Okay, this could be due to large myocardial infarction, arrhythmia, acute mitral regurg, ventral septal defect, myocarditis. Okay, the central venous pressure will be high because there is reduced venous return and there is back pressure in the systemic venous side and the pulmonary venous side. Okay, the pulmonary capillary wedge pressure will be increased. Okay, we differentiate between the cardiogenic shock and hypovolemic shock by the central venous pressure, which will be higher in the cardiogenic shock and will manifest as jugular venous distension and lower limb edema, and the pulmonary capillary wedge pressure, which will manifest as bilateral basal crepitations on auscultation in the cardiogenic shock, and simply this will be absent in hypovolemic shock. Okay, the obstructive shock is a bit tricky to differentiate between it and the cardiogenic shock, but here we look for other signs to diagnose cardiac tamponade or tension pneumothorax or pulmonary embolism. Okay, obstructive shock is due to mechanical block to either filling the heart or the flow of the cardiac output. Okay, pulmonary embolism block the right-sided heart to deliver blood to the left side and therefore reducing the left ventricular and diastolic volume and therefore reducing the cardiac output. Okay, intention pneumothorax and cardiac tamponade impair the cardiac relaxation, therefore impair the cardiac filling. Okay, the central venous pressure will be increased because there is decreased venous return to the right side. Okay, pulmonary capillary wedge pressure will be variable, so don't depend on it. Okay, finally we have the distributive shock. This is due to pathological vasodilatation to the capillaries, opening the capillary pores, allowing plasma leakage, okay, causing maldistribution of the plasma and reducing the effective circulatory volume. Okay, this could be due to sepsis, anaphylaxis, neurogenic shock, which the body loses its sympathetic tone over the blood vessels in neurogenic shock. Okay, pulmonary capillary wedge pressure and central venous pressure will be low, okay, because of the reduced effective circulatory volume and could be normal. Okay, the cardiac output will be increased early because of the vasodilatation okay, and the reduced systemic venous resistance, the venous return increases to the heart, and this allow the cardiac output to increase, but finally it will fail and cause decreased cardiac output. Okay, as just said, due to the vasodilatation, there is reduced systemic venous resistance. Okay, and this allow blood to return faster to the heart. Okay, and this impair the oxygen extraction, so we will have increased oxygen venous content. Okay, and the skin, because of the skin blood vessels vasodilatations, will feel warm and flushed. Okay, so these are the key points to differentiate between them.